Good afternoon, and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. The planners and speakers have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. A link to the event evaluation will be shared at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Oliver Glass. Dr. Glass was born in Canada and spent part of his adolescence growing up in California and Washington State. He completed medical school in Poland before matching in psychiatry residency at East Carolina University. He went on to complete a geriatric and forensic psychiatry fellowship at Emory University. Dr. Glass was recognized by the United States Immigration and Citizenship Services with the rare EB-1A visa that is also known as the Einstein visa. This is the highest green card classification pathway for individuals immigrating to the United States. Dr. Glass has published numerous publications in the field of psychiatry. His work has achieved approximately 360 citations and is growing monthly. Dr. Glass serves on the editorial board for the American Journal of Geriatric Psychiatry, where he is most often assigned legal and forensic articles. He was formerly the editor-in-chief for the American Journal of Psychiatry's Residence Journal. Dr. Glass also serves on the Geriatric Committee for the American Academy of Psychiatry and the Law. Dr. Glass is recognized nationally and internationally as a psychiatrist. He has achieved clinical associate professorship status and is affiliated with the Medical College of Georgia, Augusta University, and University of Georgia Medical Partnership. He is also an inpatient psychiatrist with Northeast Georgia Medical Center. In his spare time, he spends time with his wife, an 18-month-old son, and 2 English bulldogs. Please join me in welcoming Dr. Glass.
Thank you for that introduction. On my way here, my wife told me not to be too witty, charming, or intellectual, just to be myself. So I'm presenting today on forensic psychiatry in late life. I have no financial disclosures. So these are 2 topics of ethics that I want to point out that I want you to think about as I progress through this presentation. It'll make sense the more I talk through this presentation, and hopefully by the end of the presentation, you'll have a better understanding of some of the ethical and legal issues that are relevant to older age individuals. So in terms of beneficence, the actual meaning of this word means to do good and to avoid harm. And that's essentially what our role is as a physician. But we also want to respect autonomy. And autonomy, of course, is allowing the patient to be independent, freedom from external control or influence. So again, think about these 2 things as I talk about some complex topics. A lot of us are familiar with this chart. These are the criteria that were announced by Applebaum, university professor at Columbia, that talks about, what can we do to assess an individual to see if they have the decision to make, a treatment decision. So this is the capacity decision-making criteria. We have the communicate a choice criteria, which we're asking the patient or trying to assess to see if the patient can clearly indicate preferred treatment options or a option. So the physician's approach would be to ask the patient to indicate a treatment choice. And an example of that would be, have you decided whether to follow your doctor's or my recommendation for treatment? That would be a question. Frequent reversals of this choice or of a choice because of a psychiatric or neurological condition may indicate a lack of capacity. But we have to be careful because individuals have the right to change their mind. So it gets a little bit complicated, but this is again falling into that ethical issue about autonomy. We have to understand, or the individual has to understand the relevant information that's being discussed. So do they grasp the fundamental meaning of information communicated by the physician? And the physician's approach would be, in this case, to encourage the patient to paraphrase disclosed information regarding medical condition and treatment. So a question could be, please tell me in your own words what your doctor or I told you about. And so information to be understood includes the nature of patient's condition, nature and purpose of proposed treatment, possible benefits and risks of that treatment, along with alternative approaches and their benefits and risks. Another criteria in decision-making capacity is the ability to appreciate the situation and its consequences. So the patient's tasked with acknowledging the medical condition and likely consequences of treatment options. And the patient is asked by the physician to describe views of that medical condition, the proposed treatment, and the likely outcomes. And courts have really recognized that patients who do not acknowledge their illness cannot make valid decisions about treatment. I want you to remember that, because as I start discussing some of the legal competency issues and capacity issues, that continues to be a highlighted topic. And also know that delusions or pathological levels of distortion or denial are the most common causes of impairment. And then we also want to be able to see, perhaps this could be argued as one of the more important criteria, but they're all arguably equally important depending on the circumstance. But we want to be able to see that they reason about the treatment options, so that they're not just saying yes or no or going along with something, that they're actually putting in a little bit of cognitive exertion, so to speak, into that decision. So the patient's task is to engage in a rational process of manipulating that information. And this criteria focuses on the process by which the decision is reached, not the outcome of the patient's choice, meaning that the patient may make a decision that's a bad choice in your view, but it's still something that they've manipulated in their mind and they thought it was the choice that they want to make. So when we look at this is very simple of a graph, but it's highlighting the importance that as disease severity progresses, autonomy goes down in terms of how we should weigh the patient's decision making. So say there's a very severe delirium and the individual wants to withdraw from treatment that would then cause them to die. We naturally would put less weight on their autonomy at that point and focus more on beneficence. We want to be able to do more good for that patient and arguably make a decision that the patient would make if they were in their right state of mind. We're familiar with the MOCA. This isn't just a slide to say, oh, we got the MOCA, but I want you to think about these domains as I talk about some complex legal issues later. We have the visual spatial executive functioning domain, we have the naming domain, the memory, attention, language, abstraction, delayed recall, and orientation. Some cases where someone may lack capacity or competency may be very clear because they're not oriented. They have no attention span, or they may become more complicated where there's certain deficits in executive functioning. So just think about these domains, and also it's important to recognize that you're using this kind of test like the MOCA to collect data so you can make a really accurate assessment of that individual's capacity or competency. So some examples of medical legal topics in psychiatry include, obviously, the capacity to make decisions, research ethics in geriatric psychiatry, and the balance of autonomy and beneficence, advanced healthcare planning, surrogate decision-making, elder abuse, financial capacity, testamentary capacity, and guardianship. We also see a lot of capacity to stand trial evaluations of older age individuals, individualized treatment planning for aging people in prison, IRS and impaired taxpayers, sexual consent. So this would be topics related to elderly individuals engaging in sexual activity when cognitively impaired, such as married couples. At what point does that become an issue? Murder. And so I'll talk about some civil cases or civil topics, and then I'll talk about some criminal, and then you'll see how they can also overlap. In terms of testamentary capacity, this means, can the individual make a will? If they have assets, if they have a home, if they have equity, and they want that money to be passed on once they pass away, and they're making a will, did they have capacity, the ability to make that decision? And were there any issues when they made that will, when they were writing that will? So as the population is aging, real estate equity and retirement savings will be held on to them for longer. We're going to be seeing more and more of these issues emerge as the years go by. More individuals with cognitive decline will be responsible for the wealth in the world. And so I would like to read from a recently published article and just kind of follow along. All this will start connecting to even some of the criminal cases later on in this presentation. So testamentary capacity assessments have traditionally not drawn much attention in general geriatric or forensic psychiatry training programs. Even if the topic is touched upon in certain educational lectures, trainees are not expected to know how to perform such evaluations. With a population that's aging and who will remain alive longer than previous generations, retirement savings along with real estate equity, among other assets, will be retained longer. This means that the retention of such wealth will ride with persons who face unique older age challenges such as cognitive decline. If psychiatry trainees are not adequately trained in testamentary capacity, it could be assumed that such evaluations will either be ignored, performed by many who are not skilled to do such assessments, and or limited to a specialized few. So it's currently up to lawyers and triers of fact, and triers of fact would be like a judge, to give weight to the opinion of a psychiatric expert on the topic of testamentary capacity. Therefore, non-clinicians are deciding on whether the expert meets an arbitrary threshold for performing such assessments. And if a so-called expert performs an evaluation for testamentary capacity but does not adequately measure whether critical deficiencies are present in the testator is the one making the will, the entire assessment should be invalidated. For example, if the expert asks the testator about whether they know who their natural heirs are, but fails to take into account whether undue influence may be at play, the expert, in essence, intentionally or unintentionally permits an abuser to prevail in obtaining an inheritance. An undue influence means that someone is really like imposing their own will onto the individual who's the victim. And in this case, it would be the one making the will. It is highly critical for the testator to be assessed for whether they can thwart undue influence, meaning they can resist it. An inability to thwart undue influence indicates the testator does not have testamentary capacity. Likewise, if a so-called expert evaluates a testator but does not measure executive functioning ability, along orientation and attention span, how can this assessment be valid? So just as I was mentioning with the MOCA, think about those domains. A testator who thinks they are living in the years of their first marriage, despite being married 3 times, may be making decisions without remembering that several children from future marriages exist now. If the testator does not even know their own name, how can such a person be deemed to have testamentary capacity? Finally, if a testator cannot perform basic executive function tests, such as clock drawing, how can they participate in sophisticated inheritance planning? So this provokes questions about how testators may become victims if they're unable to thwart undue influence. And hired gun type of experts, meaning an expert witness who's hired by one side versus the other and paid high amounts of fees or amounts of money, may neglect certain components of a testamentary capacity evaluation depending on who hires them, which leads to ethical issues. This kind of situation not only impacts the testator, but the affected family members and the following generations. So there's this measure called the Glass Testamentary Capacity Measure that I came up with that's been recently published, and it provides guidance to the legal system, to expert witnesses on this topic. So, number one, does the testator make a reality-based decision regarding the inheritors of the will? Does the testator needs to rationalize a decision that's not based on a falsified reality or delusional thinking. Knowledge of wealth is number two. The testator understands the extent of their valuable possessions that would be passed down to the inheritors. Do they even know the extent of what they have? Number three, undue influence evaluation. Assess for whether there was any evidence of undue influence at the time of the will creation. Ability to thwart undue influence evaluation. A collection of evidence pointing towards the testator's ability to thwart or inability to thwart undue influence. This can not only be helpful in bulletproofing a will at the time of creation, but may bring ethical concerns into question. Executive functioning assessment. Testator's performance on a widely recognized measure of executive functioning can be used to signal or concern or show confidence or concern in the testator's cognitive ability to write a will. An orientation assessment, we want to make sure that they're not lacking orientation because that can be evidence that they're not having capacity. Attention assessment, the testator should be able to demonstrate the ability to have sustained attention. The trick is sustained, not just for a brief moment, regarding the relevant topic of will creation. Lack of a lucid attention span when creating a will acts as evidence of lacking testamentary capacity. And then knowledge of natural heirs. Do they even know who their natural heirs are? Or are they just signing a will onto someone they met on the internet? This is particularly relevant in scenarios where the will deviates from the natural heirs. Evaluation of brain imaging studies. While not an absolute indicator, brain imaging studies of the testator act as supplementary evidence in validating or invalidating testamentary capacity. So I presented at the American Academy of Psychiatry and the Law with Dr. Ash from Emory in 2018, and we were really showing that this is a growing issue because every day 10,000 US baby boomers turn 65 years of age, and as many as 60 million Americans suffer from Alzheimer's or will by 2050, which is an increase from 5.3 million in 2010. And there will be an increased need for these assessments. And so we know that normal aging results in thinning of the anterior insula, which is that brain region, which leads to an impairment in discerning whether someone is trustworthy. Meaning, if you have thinning of the anterior insula, you may feel that other individuals are trustworthy more than they should be. Think about telemarketers, individuals that are participating in schemes. A lack of financial testamentary capacity may be a risk for financial exploitation. So this is where it crosses over into the criminal realm. Testamentary capacity guideline development by forensic psychiatrists with geriatric expertise is lacking, is what we were bringing up even back then. So in terms of decision-making neuroanatomy in financial decision-making, there are these three regions that have been published that show significant relevance. The anterior cingulate cortex, which has a role in sorting conflicting options and outcome processing. The dorsolateral prefrontal cortex, which integrates multiple sources of information. The orbital frontal cortex and limbic pathways, which are involved in reward-based and emotional decision-making. So here's a potential scheme that I'd like you to follow along with. This is where it becomes It goes from civil case to criminal. Miss Jones, not a real individual, but that's just a fake name. A 70-year-old Caucasian female becomes widowed after her husband dies. The announcement is made in the local newspaper's obituary. She receives sympathy flowers with a card signed by an individual named Bob Smith. The next day, she receives a bill for $70 for the flowers, which she pays by filling out the attached form and mailing it back to the sender. The attached form requested her bank account information and social security number. Mr. Smith calls her the same week and reminds Miss Jones that he was her husband's close friend from several years ago. They begin to have daily phone conversations. Upset that her daughter only calls once a week, Miss Jones writes Mr. Smith into her will. Mr. Smith offers to assist Miss Jones with her bills and sets her up with online banking. 6 months later, the bank informs Miss Jones that her account has gone into overdraft. Miss Jones calls Mr. Smith for advice, as she does not understand how she no longer has money in her checking account, but a full voicemail message turns on. Afterwards, Miss Jones calls her daughter and explains how she has no money in her account. The daughter goes to the bank with Miss Jones, where it's discovered that over 30 online ACH transfers were made to various accounts in the last 60 days. The police are called and the investigation is initiated. The police asked Ms. Jones whether she had contact with anyone unusual in the days leading up to this event. Ms. Jones tells police about her interaction with Bob Smith and later reveals that she also added him to her will. Adamant that Bob Smith is a good person, she refuses to remove Mr. Smith from the will. The daughter requests a forensic psychiatric evaluation of Ms. Jones. So, when doing an assessment, the evaluator needs to determine whether the testator understands, again, who his or her natural heirs are. She's clearly, most likely would be able to acknowledge that in this case. But we have to also understand that the further the will departs from the natural heirs of inheritance, the more investigative effort is needed by the evaluator to ensure that the testator has a high degree of decision-making ability. So, it's different if you're changing your will so it's going only to your daughter and not to your son, rather than 50-50. But it requires a higher level of decision-making ability to say, it's not going to any of your children, it's going to Bob Smith. When there may be contention among family members, a video recording of testamentary capacity may be warranted. Some people may choose to do this ahead of time when they know they don't have any cognitive decline, and that could be thought of as sort of bulletproofing. And there may be some risk to doing that as well, which I'll discuss. The testator should rationally explain the reasoning and circumstances that influence the decision to change a will from the natural path of inheritance, and a timeline tracking any abnormal behaviors, and the decision to create or change the will is essential. So, did the individual start developing a mood disorder or some kind of psychotic disorder at that time, or some medical issue that may be contributing to cognitive change along that time frame? That would be very important to know. And then, of course, the evaluator should assess whether the testator is being subject to undue influence. Some may argue that lucid intervals, such as what you would see in Lewy body dementia or delirium, will not last a sufficient amount of time for an individual to change their will during that interval. But if for some reason a will is altered or created during an apparent lucid interval, it could be argued that there's still an ongoing cognitive influence of the underlying medical condition. So that would still be a red flag. The evaluator should attempt to evaluate the individual's cognition to see if the deficits persist during the so-called lucid interval. And the evaluator should not mistake an alertness with the testator's testamentary capacity. So it's not enough just to look alert. The evaluator should not mistake an alertness, but also the individuals with severe frontal lobe deficits, as may be seen in frontotemporal dementia, may act in a disinhibited and impulsive manner, but may be deemed by some as nonetheless lucid. So these are complex topics once you start involving the variety of cognitive deficits that could occur. It must be remembered that delirium not only causes an individual to wax and wane in consciousness, but is associated with global cognitive dysfunction. And while the testator with delirium may make a decision while he or she is fully conscious, global cognitive dysfunction could be present. So we need to get collateral information from family members, if we can, or close friends, because that's very valuable. It could also point towards whether an abusive relationship exists. And though limitations exist, there are scales that could help attempt to see whether there's an undue influence, susceptibility. And loneliness should be assessed by the evaluator. As seen in the case example, Ms. Jones became widowed and she was more susceptible to becoming financially exploited as a result. And brain imaging studies show consistent changes that are associated with dementia, and anterior insula thinning can be supportive in the forensic assessment. After death, sometimes the question comes up and the individual is no longer alive. So the evaluation will have to focus on medical records and psychiatric reports and individuals who knew the person before and after. And the evaluator should understand that the people interviewed may be biased because they may have a financial gain depending on which way that decision would occur. If applicable, the forensic evaluator should attempt to gather evidence that would prove the individual had significant decision-making impairments, and the evaluator should determine whether there was evidence of undue influence when the will was altered or created. In the United States, the level of evidence needed to demonstrate testamentary capacity may differ depending on the particular state. So you got to also think about what the threshold is for each state. And then we talked about video recording. That could be used as a way of bulletproofing. It may resolve issues of contention later, but then the question also is, was the video recording done as a way of undue influence on the individual, which I'll talk about or demonstrate a little bit later. So reading along with this recently published article on undue influence and financial decision making, this is just to paint a picture, so just follow along. A person's dignity is linked to their decision making. In fact, when a victim is abused, they are deprived of their dignity in some way. For example, when an abuser points a gun at the victim's head and says, "Give me your wallet," the victim is not only forced to give their wallet, but their dignity as a human being is deprived in that very moment. It is without question that the criminal in this case is performing abuse and imposing undue influence on the victim. Imagine that a widow with severe dementia retains knowledge and memory of their spouse recently passing away. If the widow receives flowers with a bill attached requesting her credit card information to be mailed back to the schemer, is there any undue influence at play? The criminal in this case is targeting a vulnerable individual who lost their ability to recognize a scam and thwart undue influence. Having lost her spouse while also experiencing emotional distress, she could be more susceptible to certain poor choices. Instead of a gun being pointed at her head, forcing her to give her wallet or give them her wallet, a scheme has been presented to the widow that exploits her mind's vulnerabilities. Normal human behavior during periods of loneliness can involve seeking out social connections. It is well known that isolation and depression are highly correlated. The intuitive antidote to isolative behavior is to interact more with others. But if that attempt to interact more involves answering telemarketing calls and falling victim to their schemes, negative financial consequences will result. So similarly, the lonely person may decide to connect with others online, potentially forming what he or she thinks are deep relationships. It could be imagined that a scenario emerges where the individual gets influenced by a new friend or partner, perhaps of similar age or much younger. What if that person is the only individual regularly socializing with the victim each day? What if the ultimatum eventually gets presented to the victim with the statement, "Give me your money, or else I'll not love you anymore"? Perhaps the communication will not be so blunt, but even if communicated more subtly, It's like the scenario above where the victim had the gun pointed to their head. And so the Glass Testamentary Capacity Measure provides framework for the psychiatrist or psychologist tasked with performing a testamentary capacity evaluation. And it may be referenced by lawyers and triers of fact in those kind of contested scenarios. Nonetheless, undue influence must be questioned when an evaluator is assessing a contested will or if there's investigation of financial exploitation. And a lot of this talks about the bulletproofing, but I say at the end, who's to say that the bulletproofing was not a result of the undue influence in regards to videotaping? So when talking about thwarting undue influence, this is actually something that's not even discussed a lot in forensic evaluations. It's being talked about from time to time, and it's recognized as something that's needed to be done, but it often goes ignored. So we're wanting to see if, in a case of testamentary capacity, if the individual can stick to their guns, so to speak, and resist persuasion by another that runs contrary to their wishes. If not, it can be argued that an individual did not demonstrate testamentary capacity. And so there's not many instruments that help with this, and I'm not aware of any gold standard instrument for assessing an elderly individual's ability to thwart undue influence. So therefore, we need geriatric psychiatrists and psychiatrists that are interested in these topics to aid the courts in being able to provide evaluations and expert opinions on whether that testator can indeed thwart undue influence. Because if you're unable to do it, then you are at direct risk of being financially exploited. So say an individual with early or late onset dementia is living with their payee, so someone who manages their money. Maybe the payee is spending all the testator's money. Perhaps the testator is also malnourished due to not being provided enough food because of the payee's behavior. The geriatric psychiatrist may order a brain scan that demonstrates widespread cortical atrophy. The geriatric psychiatrist may obtain collateral information from friends and family who state that the testator was always a type A personality who vocally advocated on the topic of social issues. However, over the past year, the testator became less social, corresponding with when the payee was appointed, and the geriatric psychiatrist could then provide an opinion to the court regarding factors that negatively impact the testator's ability to thwart undue influence. So the presence of elder abuse, the presence of abnormal brain imaging, and a shift away from their baseline behavior are key factors in this case. So it could be slam dunk, or it could be very much in the gray. And sometimes experts may have different opinions on this. To make matters more complicated, we must consider that when we ask for collateral information from relatives or friends, they may have a financial incentive to prove undue influence existed, particularly if they were excluded from the will. All right, so shifting to murder, which is a little bit of a shock, because we were just talking about kind of testamentary capacity and what on earth does that have to do with murder? My goal right now is just to give you a better appreciation for the legal issues in older age individuals, but also to show you the connections. Certain things psychiatrists can do and teach the courts. There are certain things that are relevant in both cases. So in a murder case, there are certain questions a forensic psychiatrist or a psychiatrist hired to do forensic work should ask. Did the defendant have any prior mental health history? Were substances involved? If so, what substance and how long ago was the last use? And we're talking about at the time of murder. Was there a recent change in the defendant's behavior prior to the murder? What was the defendant's behavior like for the majority of his or her life? Did something change in the last year? Do you see the pattern of thinking that I'm showing you? There are similar steps that you want to use when coming to assess whether the individual was in the right state of mind when they were committing a murder. Did someone influence the defendant to murder, and perhaps they were living in an environment full of criminals? Did the defendant know who he murdered? Is it consistent with reality? Do we know if the defendant was oriented at the time of the murder? There's something different between premeditated murder, where someone plans a murder, and when someone impulsively picks up a gun, is confused, and pulls the trigger. So in a murder case where you're asked to do a competency to stand trial evaluation, meaning you're wanting to know, can this person even go to court and defend themselves against the charges presented to them? Because of course we don't want to violate their civil rights and just send them to court and they agree to all the charges just because they're confused and they get sent to prison for the rest of their life. We want to be able to know that they can, in some ways, thwart the accusation, sort of like in the financial sense. But really, it's them defending themselves and using all those cognitive domains. So we want to know, are there concerns for the defendant to, are there concerns that the defendant doesn't even have competency to stand trial? Because we're not asking this question in every individual, but what's triggering that first question? If they are already found competent to stand trial, how fragile is the defendant's competency to stand trial? Because even if they were competent yesterday, perhaps something happened today that has clouded their ability to be competent. So what factors may lead to the defendant to become incompetent to stand trial? So in terms of landmark cases, there's Dusky v. U.S. This is a famous case where Milton Dusky, a 33-year-old, was charged with kidnapping a 15-year-old girl across state lines. And two of Dusky's juvenile accomplices, 14 and 16 years of age, raped the girl. Dusky was diagnosed with schizophrenia. In terms of the competency report, an expert psychiatrist opined that Dusky was not able to assist counsel, and you have to assist counsel to be competent to stand trial. And so there was the opinion that Dusky was not able to assist counsel in his defense and did not properly understand the proceedings. The judge nonetheless ruled that Dusky was competent to stand trial since he appeared to understand the nature of the charges against him and was oriented. Dusky was convicted and sentenced to 45 years in prison, but Dusky appealed that the court made an error in finding him competent to stand trial. The Supreme Court reversed the conviction against Dusky. The Supreme Court stated that there was insufficient evidence to support the district court's decision that he was competent to stand trial, and this led to the two-pronged test required to be competent to stand trial. A defendant has to have sufficient present ability to consult with his lawyer with a reasonable degree of understanding. The defendant has a rational and factual understanding of the proceedings against him. This is called the two-pronged test of the Dusky standard. So when talking about fragility and competency to stand trial, are there signs of a neurocognitive disorder? What is the current health status? Do multiple comorbid health conditions exist? Is the defendant receiving adequate mental health and medical health care? Is their blood pressure out of control? Is a delirium emerging? Is there something going on, like a stroke, that may have caused them to no longer be competent to stand trial? Perhaps there's some kidney functioning issues or electrolyte disturbances. And we know that neurocognitive disorders tend to progress. So at what point in time do you think it will progress to the point where they'll no longer have competency to stand trial? But also emotional stress can play a role. If someone's under immense emotional distress, it will impact their ability to stay calm and make rational decisions and manipulate information, as I described in the beginning, as one of the criteria for decision-making capacity. Homebound restrictions will lead to isolation and depression, which can also weigh on the individual's cognition. And incarceration detention experiences may reignite childhood trauma, which in itself brings up a lot of issues in terms of their ability to be to be able to cognitively manipulate information and even have attention and at times orientation. In Drope v. Missouri, James Drope was accused of raping his wife. This is another landmark case. The defense attorney submitted a pretrial request for postponing the trial so Drope could receive a psychiatric evaluation with treatment. The attorney's request was supported by a psychiatric report that provided information regarding Droop's psychiatric history and need for treatment. The trial court denied the motion and allowed the case to go to trial. Droop's wife testified about Droop's irrational behaviors, including his attempt to choke her before the trial. Droop attempted suicide by gunshot, but failed to kill himself during this period. And the defense attorney requested a mistrial because it was argued that Droop needed psychiatric hospitalization, and the trial court found that Droop's absence was voluntary and nonetheless continued with the trial. Droop was convicted and sentenced to life in prison, even though he was not at the trial. Droop appealed to the U.S. Supreme Court, stating that he could not waive his right to be present if he was incompetent to stand trial, and argued that due process was violated due to the court failing to order competency to stand trial evaluation. So the Supreme Court built on the Dusky case with this landmark case, which happened 15 years later. The trial court must always be cautious about whether a defendant may have become incompetent, is what the Supreme Court ruled. The trial court must request a competency evaluation when there is sufficient doubt of the defendant's competency to stand trial. So there may be serial competency to stand trial evaluations throughout the whole court process for that defendant. To put it in the U.S. Supreme Court's words, evidence of a defendant's irrational behavior, his demeanor at trial, and any prior medical opinion on competence to stand trial are all relevant in determining whether further inquiry is required. But even one of these factors standing alone, in some circumstances, may be sufficient. The evidence of prior mental instability, a suicide attempt during a trial, and a psychiatrist's report recommending psychiatric treatment should have been sufficient to alert the trial court to the need for further evaluation of Droop's competence to stand trial. Another landmark case, Godinez v. Moran. The defendant was convicted of 3 counts of murder and found competent to stand trial. The defendant waived his right to an attorney and pled guilty. The court sentenced the defendant to the death penalty. It's a pretty significant consequence there. Moran claimed that he was mentally incompetent to represent himself after that conviction. The Ninth Circuit Court of Appeals ruled that the competency to waive constitutional rights requires a higher competency threshold standard. And the ruling was reversed. But the Supreme Court then stepped in and said that if you're competent to stand trial, that threshold is the same as waiving counsel and entering a guilty plea in regards to that level of competency. Therefore, if you are competent to stand trial, there is no difference in threshold. I bring this up, and I'll kind of go through it a little bit more quickly due to time, but the courts want to know about adverse childhood experiences in terms of mitigating factors, and there's a lot of data on this, but essentially if an individual has gone through a lot of adverse childhood experiences, they're at increased risk for a variety of poor health outcomes, and you can see that here. Even early death becomes a consequence. This pyramid here has a connection between adverse childhood experiences and disrupted neurodevelopment and social, emotional, and cognitive impairment and the adoption of high-risk behavior and disease and social problems, and unfortunately early death at the very top. And here's another way of pointing out adverse childhood experiences. You can see depression, anxiety, suicide, PTSD are related, and HIV, STDs. There's data to support that the incidences are connected, and drug and alcohol abuse, and cancer, diabetes, TBIs, fractures, burns. Unfortunately, there's increased risk between all of these factors. So as public health research and knowledge of how much the environment outside of the home can influence a child's well-being has expanded, the original list of 10 conventional ACEs have been expanded to include 5 additional ACEs. And so we also know that living in foster care is connected racism, neighborhood safety, community violence, and bullying. It's just important to recognize these things because when someone gets charged with a crime, the courts will be interested to know how this individual's upbringing was different from the average individual's. And this is an example of the questions for ACEs. So you get a point in each section. But there's certain examples, like did you live with anyone who went to jail or prison? Did your parents or adults in your home ever hit you, punch you, beat you, threaten to harm each other? Did you live with anyone who had a problem with drinking or using drugs, prescription drugs? Did you feel that no one in your family loved you? So you can kind of look at some of these questions and you'll get a score. And that score, if it's quite elevated, you can then compare to kind of what an average individual's score would be. And it's also been linked to arrest and incarceration. So we want to be mindful of that. And it's been connected to a greater risk for dementia. So in terms of mitigation, what adverse childhood experience did the defendant experience? So mitigation, by the way, is the court wants to know, should this person be sentenced to such a severe level or kind of the maximum sentence, or is there something that should be taken into consideration so the individual gets a lesser sentence? And so as an expert, you want to look at the ACEs, the adverse childhood experiences. You want to look at the neurocognitive disorder and see if that increases the defendant of being impulsive, paranoid, irrational. And then you also want to know, like, should the defendant be punished to the same extent as an adult? So, if someone's older, I don't know, say they're 80, 90, et cetera, and they're being convicted of a crime that's for all adults, should they get 30 years? Should they get the death penalty? Why not? Those are questions to ask yourself. Why is it different for them? On the flip side, to kind of make it more clear, like should a 13-year-old be given the death penalty for committing murder? Should a 9-year-old be given the lethal injection as a form of the death penalty, or be killed by a firing squad if convicted of murder? So the same applies really to an individual on the opposite end of the age spectrum. So if death penalty is being pursued, what is the likelihood that the defendant's neurocognitive decline will affect competency to be executed? So if they did get a death sentence, so to speak, it could take 10, 20 years or whatever for them to actually get executed. So how do we know they're competent to be executed at the time that they're supposed to be executed? Meaning, are they aware of why they're being executed? Because you can't execute someone who's not aware of what's happening or what the charges were and what the circumstances were for why they're in that situation. Will incarceration increase the risk of the defendant being exploited by other inmates? And if the defendant requires shackles and handcuffs, will that lead to increased risk for falls and potential head injuries? So if someone's got like Parkinsonism or shuffling gait and you're putting shackles on their legs and they're falling all the time, what accommodations should be made for them? This is kind of a drastic difference, but in terms of the legal sense, when writing a legal report, they like images. So on the left, you have a normal brain. On the right, you have a dementia type of brain. You can see just the differences there. They're quite drastic. Culpability, which is, basically you're trying to see whether there were certain factors led to this individual committing the crime that should be taken into consideration that would essentially lessen their punishment as well. So was there evidence that the defendant had neurocognitive deficits at the time of the crime? Was there evidence that the patient's cognition was clouded? Was the defendant a victim of some form of exploitation at the time of the crime? And if so, is there a concern that the defendant was unable to thwart undue influence? And so I talked about sort of the course And the courts also want to know whether rehabilitation of the defendant has occurred. So when they're doing sentencing, if the person's been incarcerated for a few years, and sort of there's an appeal, so to speak, they want to know, were they rehabilitated? And it's not that the prisons or the jails need to rehabilitate the individual, just that has the condition or the factors that have led to that individual committing the crimes been rehabilitated. And it really falls on the individual themselves. So when doing cognitive decline sentencing, we want, when there's sentencing and we're looking at cognitive decline, we want to be able to know, is this individual compared to the average person more impulsive? Was there personality changes from baseline? Were they easily influenced? Was there any evidence of difficulty thwarting undue influence? And was there a correlation with the memory impairment at the time of the crime? And then they're going to want to know what defines an individual with cognitive decline. So, laying out brain deterioration, that there's risk of further progression, examples of their behavior that's consistent with the cognitive decline, changes in performance such as in ADLs. And then the question gets brought up, how do you know it's a cognitive decline versus an intellectual disability? And then laying that out is important. And then I make this as a separate slide because impulsivity in itself is looked at separately. So there's something that's kind of referred to as an impulsive brain. And an argument can be made that this individual's brain is simply more impulsive than the average, and it's outside of their control. And so it goes into discussions regarding brain structure and the impulsivity connections. And if there's been a decline in cognition and there's evidence of brain deterioration, how does that affect sentencing? These are questions that get brought up in court. And adult crimes tend to have planning and intent as common components, as I mentioned earlier. And so this goes into that premeditated question. And assuming evidence suggests the brain is more likely to be impulsive, there's the potential argument of reduced culpability, so that they really weren't fully responsible in a sense for the crime. Even though they did the crime, there's sort of a burden that should be taken off of them in terms of responsibility. And so those kind of situations get brought up commonly in history of traumatic brain injury, intellectual disability, and cognitive impairment. So I'll end it on this note. This is an interesting topic just to agonize over, published in the New York Times, but this was happening around 2015. And we'll just kind of read it together. There's no question that Donna Lou Rayhans had severe Alzheimer's. In the days before being placed in a nursing home in Garner, Iowa last year, Mrs. Rayhans, 78, could not recall her daughter's names or how to eat a hamburger. One day, she tried to wash her hands in the toilet of a restaurant bathroom. But another question has become the crux of an extraordinary criminal case unfolding this week in an Iowa courtroom. Was Miss Rayhans able to consent to sex with her husband? Henry Rayhans, 78, has been charged with third-degree felony sexual abuse, accused of having sex with his wife in a nursing home on May 23, 2014, 8 days after staff members there told him they believed she was mentally unable to agree to sex. It is rare, possibly unprecedented, for such circumstances to prompt criminal charges. Mr. Rayhans, a 9-term Republican state legislator, decided not to seek another term after his arrest. Michelle Dornbier, a social worker at the center, and Dr. John Bodeker, Mrs. Rayhans' family doctor, testified on Friday about her scores on a test to assess memory and orientation. In May 2014, she scored 0, unable to recall the words sock, bed, and blue. But Ms. Dornbier acknowledged that Mrs. Rayhans was always pleased to see Henry, and Dr. Bodeker acknowledged that intimacy is beneficial for dementia patients. Ms. Dornbier testified that the Concord Care Center allows consensual sex between residents, but she said that May 15, 2014, family members, including Mr. Rayhans, were given a care plan establishing simple routines for Mrs. Rayhans, including limited outings with Mr. Rayhans, mostly to church on Sunday. Ms. Dornbier, prompted by what she called concerns from Mrs. Rayhans' daughter, Susan Bruns, that Mr. Rayhans was engaging in inappropriate sexual contact wrote at the bottom of the plan, given Donna's cognitive state, do you feel she's able to give consent for any sexual activity? The center's Dr. John Brady wrote, no. Mr. Rayhans was told the recommendation against having sex and indicated it would not be a problem, according to Ms. Dunshee. One obstacle, dementia symptoms fluctuate. Patients may be relatively lucid in the morning and significantly impaired in the afternoon. What may be appropriate on one day may not be appropriate the next week or at a different point that same day, said Anne Christine Frankowski, Associate Director of the Center of Aging Studies at the University of Maryland, Baltimore. Yet desire may survive long after names and faces are forgotten. Physical intimacy can benefit dementia patients, experts say, calming agitation, easing loneliness, and possibly aiding physical health. I'll let you all read more on that article if you're interested, but he was ultimately acquitted. But it does bring up a lot of different interconnected issues of exploitation, capacity to make decisions, and thwarting undue influence. And I'll end my presentation with that.
Great presentation. I was wondering, in the one point you showed, there should be some sort of a difference between somebody who's a regular criminal who got a trial for this versus somebody who has early childhood trauma. I was just wondering, like, in data-wise or in your opinion, how many people who get in that kind of crime has early childhood trauma? Is most of them actually had early childhood trauma? I was just wondering.
Yeah, I think you can make an argument that many of them have childhood trauma that's been unrecognized. You know, the reality of it all is, you know, if you hire a good legal team, they'll investigate better, and that'll be presented to the court more effectively than someone who doesn't have adequate legal support. So the question then becomes, how can we ensure that individuals are provided legal support at the correct standard to investigate that? And that's sort of where concerns emerge, because, you know, if people had the means, perhaps they would be acquitted of certain charges or would receive a lesser sentence, but because they don't have the means, they receive a harsher sentence.
Thanks, Dr. Glass.
Thank you.